Kulkarni. I'm one of the urologists at Princess Margaret Cancer Center, and we're part of the UHN. And the idea here is to introduce this trial, a phase 1b clinical trial of TLD-1433, which we've been discussing to some extent right now. I'm going to bring it back to basics about bladder cancer, and we'll go forward from there. For some of you, this may be a review. For some, it may not. So what exactly is bladder cancer? It's a cancer of the lining of the cells that line the inside of the bladder. So those cells are called urothelial cells. So the cancer is called urothelial carcinoma. That's the most common kind of bladder cancer, and that's the cancer that we are aiming to treat with the Theralase technology. There are other types of cancers, but they would not be admissible in this trial. But these are 95% of the types of bladder cancers. This is the typical bladder cancer. In the past, it used to be called transitional cell carcinoma. So if you see that we're talking about the same entity. And it may not be actually well known, but it is a very common cancer, the 5th most common cancer. But it's relatively underfunded. People mainly think about prostate, colon, breast, but bladder is right there, right underneath that. So in order to figure out how to treat bladder cancer and which patients are eligible for different treatments or different trials, we need to have a nomenclature for how bad the bladder cancer is, and that's what we call staging. So this is a cartoon of staging of bladder cancer. So this would be the inside where the urine would be, and this is the bladder wall. So that's to orient everyone. These are the urothelial cells, so these would be considered normal cells, and these mounds are the tumor. The next layer is the lamina propria, or the basement membrane, then the muscle, which allows the bladder to squeeze so that you can urinate, and then the fat that's around the bladder. Not all of the stages are listed here, but everything other than T4 is listed. But these two, T2, T3, are not applicable in this trial setting. We're looking mainly at this entity, carcinoma in situ, high-grade tumors here that are confined to the urothelial layer. Those are called TA, or T1 tumors that have just started to micro-invade into the wall of the bladder but haven't gotten into the muscle. Those types of tumors usually do not require radical therapy, and I'll talk a bit about that as well. But they have a high tendency to recur, up to 80%. So they can be a big burden to patients and to the healthcare system, and they have a high tendency to progress. And what that means is they can change from one of these to those. Those tumors, the T2 and the T3, they're going deeper into the bladder wall muscle and beyond, and require either big-time surgery or radiation or additional therapies. 75% of the tumors that originate in the bladder are actually in this domain. So the patient population is actually quite large. So how do we treat these? They're called non-muscle invasive. So if I go back, none of these are actually going into the muscle. All the other ones are going beyond the muscle. So we call these non-muscle invasive bladder tumors or bladder cancer. And so the treatment is initiates by putting in a scope called a cystoscope into the urethra, which is the passageway through which you urinate, into the bladder, and we simplistically scrape out the tumor. But that in itself is not sufficient to treat these types of tumors. They have a high tendency to recur and a high tendency to progress into more insidious type of tumors going into the muscle or into the fat. So we also will give additional treatments thereafter. And the most commonly studied, the best treatment is something called BCG. So what that is a tuberculosis bacterium from the cow as opposed to humans. It's a live bacteria that we put within the bladder. It's attenuated, so that means it won't cause or shouldn't cause infection like it would in a human, although there are cases where it can cause an infection. That's rare. And what it does is it incites the immune system, the body's own mechanisms to fight off the tumor. So there's appeal there because we're using the body's own system to fight cancers. It works actually very well, but it's not perfect. So we can decrease recurrence rates from 80% to say 50%, and progression rates to the nasty tumors from 30 or 40% down to 20 or 30%. So it's still not perfect, and that means tumors will recur, and then patients need additional treatments. Mitomycin is another kind of treatment. It's a chemotherapy. It doesn't work as well, but it is an option in some patients. So if it comes back, the cancer, which is quite common, how do we treat that? And that's a dilemma for most of us urologists because it's actually very difficult to treat. And so we have these patients coming back and we're trying different things. We're throwing more BCG at them to try to prevent these tumors from becoming invasive and spreading throughout the body. We're trying other agents. I mentioned mitomycin. Interferon was studied. It's a protein that's made in the body in response to inflammation. So to theoretically give a stronger immune response to fight off the tumors. This is a chemotherapy that's used very often when the bladder cancer has spread throughout the body. So we've tried to put that in the bladder. But again, none of these have durable responses. So if we know that BCG isn't working, the chemotherapies aren't working, we do have one method that works. It's called radical cystectomy. That's removal of the bladder. And that's a very, I guess one could say, debilitating type of operation. We remove the bladder, the urine has to go somewhere, and then the options are to create a stoma. This is a very nice looking picture. It's not usually like that. It's usually like this. It's the only kind of medicalized type of photo. I didn't know if people are going to be squeamish. It's near dinner time. But that's a stoma. So the urine is permanently going into the bag. So it's not appealing. Other options are to make a new bladder out of the bowel, which we can do in select patients. But these are big operations. They take 6 to 7 hours. 2/3 of patients are going to have a complication. Anywhere from 2 to 4% are going to die just from the operation. So we have a therapy that we've tried already that may not work, and we have this really bad therapy. So that brings in the concept of clinical trials. People want to save their bladders. They want to maintain their quality of life. They don't want to have urine exterior to their body where the bag could break, etc. So there's a big space for trials in this area. So that's the exciting thing about the Theralase laser and the photosensitizer, because for the longest time, I would say at least the past 10, 20 years, there hasn't been much in terms of clinical trials in this realm. So this is more or less a summary of what Lothar said. So the photosensitizer, the TLD-1433, is bound to this molecule called transferrin. Normal cells have this transferrin receptor, but they don't have a lot of it. So they're not going to take up a lot of the agent. Whereas these tumor cells have a ton of the receptors. They're going to suck up the agent. They'll get exposed to light. Green light is thought, so it's not going to go as deep into the wall of the bladder. So it'll spare any side effects to the bladder wall and just target the tumor. The green light causes the release of something called reactive oxygen species. So if you were to get radiation therapy for for any kind of cancer, that's the mechanism by which that works. Reactive oxygen species are damaging to the DNA, and it can cause cell death. So the idea is that those get released and the cancer cell dies. The evidence to date has been, as Lothar said, in animal and rat models and in cell culture models. So this would be the first trial in humans. And the patient population are, like I said, the non-muscle invasive tumors, those ones that haven't gone to the muscle. They have to be urothelial of origin, but again, those are 95% of cases. There are some strict criteria to get them into the trial. They have to have failed BCG. These criteria, I won't belabor the details, are very similar to what what major cancer centers around North America are using. So it's pretty standardized for what a definition of BCG failure is. So the study endpoints, I came in a bit late, but I heard Roger talking a bit about that. So it's primarily dose finding and safety, but we will also look at recurrence-free survival as well, and those are going to be primary endpoints. And then we also, as secondary endpoints, we'll look at recurrence rates overall at 3 months, at 6 months, overall survival, and overall survival at 3 and 6 months. So I've introduced myself. My major focus is actually clinically and research-wise is in bladder cancer. Bladder Cancer Canada is probably the big entity in Canada. The equivalent in the US is the Bladder Cancer Advocacy Network. So I'm on the medical advisory board of Bladder Cancer Canada as well. And I go to the BCAN meeting, the American meeting, all the time as well. So that's an invite-only meeting. So my focus is primarily bladder wherever possible. My co-investigator, so Michael Jewett is here as one, but all of us urologists at UHN will be involved in terms of putting patients into the trial. And those are our research coordinators who are involved as well, Kathy and Laura. So will we be able to complete the trial, and how fast, and is this really feasible? I think it's actually quite easily achievable. Princess Margaret has a motto to be the top, as the top 5 cancer, one of the top 5 cancer research institutes in the world. Recently, I think they should change the model because now we're number 2. So I put top 3, but we're actually number 2 in the world. So we have a pedigree to do these types of trials. We have a very high bladder cancer volume, probably amongst the highest in Canada. And we actually have a specific clinic just for bladder cancer patients called a multidisciplinary clinic. So patients who need to have cystectomies or have radiation for bladder cancer, which are not the patients for this trial, are seen, but also difficult to treat patients, which are the patients for this trial, the non-muscle invasive bladder tumors, where the BCG hasn't worked, we don't know what to do. Those are the patients we see in that clinic as well. And then finally, we have this new consortium that we started up because we've recognized that to get new agents and new trials off and running and off the ground, we need to have these patients. We have patients already at PMH, but we have engaged at least 15 to 20 urologists and community centers around Toronto. They know about this trial, so I presented it to them as well, and they're keen to send their patients down to us for enrollment in the trial. Because we have good relationships with them. And also, more importantly, like I said, there aren't a lot of options for these patients, so this is an exciting time for them. So to date, what we've done is that our research ethics protocol has been submitted, and so we're actually well into this. We just submitted it a week ago, and usually there's a back and forth in terms of amendments. And once we have approval, there are grants and contracts that we need to do with different departments within the hospital. So I would say probably within a couple months, we should be able to get this up and running.
About last year, when we were still working with subcutaneous tumors, where we had the tumor growing on the back of a mouse, photosensitizers still had to be injected directly into the tumor, we diffused nicely into it, discolored the tumor, we could treat it, and then long time later, it never came back. Reasonably good experiment, and we showed some of the first images here that was from the study done in Toledo, in Ohio, at the medical college, or medical university, how they're called right now, showing that we're actually getting more relevant tumor models, also topic tumor models, which are basically grown in the organ that we ultimately intend to treat. And some of the initial histology, which we had essentially nicely growing tumor and completely sapped tumor. What I would like to show you actually today, actually even go over these, I have something a little bit better. So here we have actually a whopping large tumor in a rat. That's 2 millimeters, considering that the rat bladder is about that big. That's a huge tumor. And when we inject the photosensitizer only, now a high resolution image from the edge where the photosensitizer would be in contact, nothing actually happens. So the photosensitizer at the used doses in that situation is really non-toxic as long as we don't have any light that is basically inserted into the fiber at the same time. Now, when we actually start treating a tumor, we have here the bladder wall, small tumor nodule, and this is now 2 days after treatment at a very low dose compared to the therapeutic dose, what we're ultimately planning. And that is what we see afterwards, that essentially the tumor is gone, we have some inflammation in the bladder wall, but for me personally, very exciting is that if you basically look at the muscular layer, they appear normal. That was one of the problems of the original use of photodynamic therapy for bladder cancer, that the muscle layers were actually damaged. the patient that had the treatment basically had, due to this, a shrunken bladder volume itself, and that released, followed through with incognitance and all the other problems. That's why it really fell out of favor. So what we see here, at least that short period after the treatment, that the muscle really looks normal and healthy. If we go to a higher dose, that is basically roughly around what we intend to do the therapeutic dose, again 2 millimeters, so large tumor, probably larger than what we ultimately will anticipate in our clinical trials. We see already here very large necrosis, hemorrhaging necrosis of the tumor itself. And here is again the muscle. They are disconnected because the tumor was sitting on a small stalk right into the bladder volume. That's why we actually have missing here a little bit the connection. But if you look at some of the high resolution images, that's the high resolution image again, or a higher resolution image of the tumor itself. There are no surviving tumor cells at this point. And again, when we are looking here at the short stretches of the red bladder we have here, the urothelium looks actually intact. There are no inflammatory cells at that section. The muscles are stretched, but this is just an issue of that large tumor have been sitting there stretching the muscle layer itself. And it looks also reasonably normal and undamaged. So it's very encouraging at this point, but really going forward, that by itself, with our approach we have selected, with the installation and the irradiation, that this is actually very promising. We are also looking, of course, for the current drug, and again, TLD-1433, that's the abbreviation we are using, is looking for other indications. And one of the points is you have to start thinking about how do we actually get the drug if you want to do a systemic administration through the bloodstream itself. How do we get it to the tumor? How do we get the selectivity? And over the last year, we have done actually a lot of work in changing the absorption. That is the dashed line here. That is the original absorption spectrum for the photosensitizer as we get it right now. We actually mix the photosensitizer with a transport molecule. That transport molecule is actually normally transporting iron, bring iron to the cells. And all tumors essentially have a higher uptake of iron. That's why the receptors which are looking for that molecule, which is called transferrin, is upregulated, is much more there, taking it up higher. So we basically can use this one now as a transport mechanism. And additionally, we're getting now also good absorption into the red and near infrared, which you would need for treating larger other solid tumors. So that is actually right now developing. Essentially in the spectral range where we're interested in, we're getting basically about 15, 20-fold higher absorption than for the drug itself. So it has a beneficial process already by getting higher uptake, higher absorption, and also higher system. TLD-1433 is the original drug. If we have pre-mixed it, and unfortunately it still doesn't come out, I've tried to play around a little bit with the contrast, but it doesn't work. I have to show you then later on my screen. Was also interested in the new thing we right now called actually Rusterin. After 40 minutes, we see a much higher increase. Unfortunately, you can't appreciate that here very well compared to the drug alone. After 150 minutes, you also see a much higher uptake. Simultaneously, and that's also very encouraging, we are looking at the dark toxicity. So what the toxicity of the drug is by itself when we are actually injecting it into the tissues itself. For the Rutherin, after mixing with the transferrin, the toxicity is actually going down. And that is, of course, helping us overall in future direction for the applications, that the systemic toxicity of those compounds is going down. Small increase in the efficacy, getting basically more of the drug in, and we actually can treat the tissues higher. And that is basically for a couple of different systems. And if we now go back to our old models with the mice, that superficial tumor that was actually treated, if we did the same treatment, same light treatment, same total drug delivered, the drug only, we get about 40% survival, long-term survival of those animals. After we have done that mixing, we're actually getting 80% survival. So again, we have taken our existing drug, for which we have already a lot of the other toxicity information which we need for the current clinical trial, but we have very good initial data that basically allows us to start thinking about other indications. Next step is Theralase and Roger, they also have acquired the right to some other compounds. Again, we're not going to replace any of the compounds we have right now. This is basically looking again for other indications. Where can we actually use them in the future? These are now not ruthenium-based compounds, but osmium-based compounds. It's part of the same subgroup of metals at that point. Chemical structure, not that interesting in. The advantages and why we basically inspired with our chemists to do the development of those compounds is that they inherently have a much higher absorption in the longer wavelengths. The point is, if you're going into the red when you're in the 600 nanometers, or after 700 nanometers when you go into the near infrared, light is propagating much better into the tissue. That allows you then, if you think about solid tumors, to start treating larger tumor volumes. And that's what we want from a physics point of view. So these are some of those compounds we are currently using, we are currently evaluating. We're looking basically how can we actually store those cells, those drugs, not very interesting right now, but we can freeze them down, we can have them on the fridge only for 2 weeks, and that stays stable, which is very helpful for us. And when we initially look again at our ability to kill cells, again in a tissue culture dish itself, what we have shown here is 2 of those compounds, plus that is 1433, not 14.3, that is an older denomination we have used. And we basically look at how much of the cells are we killing as a function of the concentration of our drug. So low concentration, no killing. High concentration, we actually achieve then a killing itself, photodynamic activity. And one of the drugs has a very similar curve as 1433 in our model system right now, in one of our model cell lines. And the other drug is a little bit more effective. This is in units of an order of magnitude. So we basically know that we can achieve the same effect, the same killing typically that is calculated, where you have 50% of your cell kills. That is reduced by about a factor of 5, roughly, on those dimensions. Again, those other photosensitizers, they can be used at longer wavelengths, and they're also effective in our in vitro systems. Over the next year, we're going to take this system, of course, through the paces for all those assays we have already developed, including the animal models itself. So these are kind of what we have done at this point, more on the biological end of the research. But as you all know, it's photodynamic therapy. It takes 2 things. It takes the biology, the biochemistry, the biology itself of the photosensitizer, and we also need light. And when we talk about the light, in the old system, or in the old models we had on the previous calculations, it was a very simplistic view. We inject the photosensitizer systemically. Then we have the bladder, which is a nice sphere. We put our fiber optic source in the middle of the sphere, and we get an equal irradiation of the surface. Well, this is the shape of a bladder, which we have gotten from a couple of CT images. And it's all but spherical. The clinical trials we are currently planning, or let's step back. Historically, in photodynamic therapy, the dose was defined by the amount of photosensitizer you would inject systemically and the light you would actually deliver to a surface, or if you have an organ, the length of the power coming out of the fiber, or from a point source, how much watt is coming out. What we are trying right now to do is change that a bit. So first of all, we say, no, we are instilling the drug. So we need to go back to the drug concentration as drug per surface area. And for the light, we also want to go light intensity per surface area. These are the dose metrics used in dermatology. And in dermatology, photodynamic therapy is very effective. Photodynamic therapy in dermatology is used as a first-line therapy for basal cell carcinoma. Yeah? Very often being done. So we want to use the same dose matrix because we believe that with those dose matrix, we actually can control the ultimate dose we want to give to PDT to the tumor to destroy the tumor, but not overtreat and damage the normal bladder wall. What we're doing right now with a different group at the University of Toronto, they have actually developed mostly some computer model programs we are using right now. This is now that bladder shape, and the color contours is now how we have calculated how much light gets on the surface area. So if we have basically a source somewhere in that tumor volume, we start moving it around. Here we have now a position where we have a reasonably homogeneous illumination of the surface, maybe a little bit of a hotspot down here. But if we move it too far out of that main axis we want to have, or if there would be too much turbidity in the tumor, we can actually then achieve very easily an overtreatment here and an undertreatment over here. So we are basically going towards the point of saying, okay, we can control, theoretically, the light distribution in the bladder, but what is actually the hardware we need to achieve that also in the clinic? And that was basically the work the engineering team here at Theralase has done in combination with some of the advice we could actually give them. And we basically have now developed a dosimetry system that is currently being reviewed at various levels. We call it the TLC-3200. You will hear that actually quite often, which is a combined system of a laser or computer-controlled laser that is delivering the light through a special cage, which I'm going to explain soon, into the bladder itself. And we have a system of a total of 12 light sensors on the surface of our bladder afterwards through fiber optics going back to our data acquisition, and we have a dosimetry tablet. So here basically laser lights coming out. That is where our probe, our 13 detectors are going to be connected itself. And that's how the whole thing actually looks like. The fiber optic here in blue that is connecting to the laser, our sensor connectors, that's all combined. And here we have that little thing that is actually going, and it fits through a cystoscope, so the physician can actually observe how it's going to be deployed. It deploys automatically by simply pulling on one of the fibers a little bit. Here you see a slightly an increased system. We have basically 3 of those bands. These are ribbons of fiber optic cables. They have very special sensors implied that it will be patented right now at this current point. And we have an axis defined that basically holds the source on the main axis of the bladder, again allowing us that homogeneous illumination. This is basically a screen the physician will see initially when he's basically testing it out. Is my position correctly? He needs to aim to have a power density on all of our 12 sensors, which is within this range. Once that is actually achieved, currently like this, then the treatment starts, and the physician is getting the feedback how very slowly the optical energy density is accumulated over the surface of the bladder. And at that point, it's then basically up to the physician to ultimately go in and say, okay, I have actually achieved that treatment over all of the surface area as it is desired for me. And at that point, then the light treatment can be terminated. And these are kind of the 3 main projects we at the Basic Science and have been engaged on over the past year since we met here the last time. I know we're going to talk now a little bit about the clinical trials per se. I'm staying around afterwards, and you can ask me any other questions, please. Okay? Thank you very much for your attention. And